Right, let's start. Good morning, all. Welcome to Aging Well. How do we resist inequalities in the new normal, shaping the future of aging care and the care workforce? This is the penultimate segment of this conversation, although it will be continuing with future webinars that are being recorded and also the Possibility Club, of which hopefully you're already a member. If not, we'll send you a link and pop that in the chat for you. The impact of COVID-19 on aging care is a story of two halves. On one hand, it's magnified some of the key problems in caring for older people, such as underfunded aging health and social care, aging inequality, and inadequate aging care workforce and care resources. On the other, it's accelerated the transition of care into the digital age, pushing the remote care practice as well as online education and training. Something we've talked about a lot is this has accelerated a lot of really exciting technology, but that also brings in potential issues with technology poverty and accessibility. And also a key thing we talked about in the last webinar is not grouping people as perceived as old. Number one, we have talked about what old is, into one huge group and making sure that it is tailored to the different needs mentally and physically of a huge section of our community. So the global reset, positive and negative, it's created an opening for change that seemed unthinkable a year ago. We've discovered a lot of things that we've been discussing across all walks of life have suddenly been accelerated in the last year. It's been the most interesting social experiment from all generations, but with the elderly in our community, maybe even more so. And we think this is an opportunity to shape what caring for older people will look like in an uncertain age. So this webinar, part of a series I mentioned, it's co-hosted by the Centre for Social Work, Innovation and Research, the Centre for Innovation and Research in Wellbeing, and Sussex ESRC IAA. And Aging Well is changing the conversation is being delivered in partnership with the Adult Social Care and Health, East Sussex County Council, and the Centre of Excellence in Research on Ageing and Care and Always Possible. And speakers will discuss 4 key problems in ageing care: ethnic inequalities in later life, a care home practice, community care practice, care education training, and support for paid and unpaid carers. Drawing examples from the UK, Finland, and elsewhere, the panel will explore how future care can offer something better and more sustainable moving forward. Let's take these lessons and let's create something better than we have already. So the speakers that we have today, we have Professor Teppo Kroger from the Department of Social Studies and Philosophy at, I'm not going to try and pronounce your university, Teppo. You can do that for me properly when you go live in Finland. He studied social care since the early 1990s and leads the Centre of Excellence in Research on Ageing and Care. And Professor Kroger will discuss 2 new surveys from Finland, focusing on people's experiences during the COVID-19 pandemic from an older people's and carers perspective. We then have Dr. Leah Baccaris, a senior lecturer in applied social sciences and deputy director of the Centre for Research and Innovation in Wellbeing at the University of Sussex. Her research interests are in studying the pathways by which the discrimination and marginalisation of people and places lead to social and health inequalities across the life course, with a specific focus on racism and heterosexism as systems of oppression. Her talk will focus on ethnic inequality in later life. We have Philip Blurton, who's a principal social worker for adult social care at East Sussex County Council, where he is leading on the implementation of the liberty protection safeguards, as well as playing a key role in the recruitment, development and retention of a high quality workforce of social care practitioners. Philip is currently leading a project group within East Sussex to understand the changes to social care practice that have taken place as a result of the pandemic. His talk will focus on the remote social practice in ageing care during COVID-19 and the ways it's likely to impact on longer changes to social work practice in older people. Last but not least, we have Dr. Lisa Chen, a social worker, lecturer and deputy director at CSWIR at the University of Sussex. Lisa's research profile is centred on the policy and practice of long-term care. This includes the quality of life for older people and their carers, care system evaluations and development, and the care force workforce within long-term care system. And Dr. Chen will focus on defining the new normal for care education training and support for the paid, unpaid and care workforce. So Aging Well, as I've mentioned, it's a project bringing together a host of activities, research and content. And a part of this, we've got a community hub. So if you've missed anything, don't worry. Annie Marie's already put the link there for the Possibility Club, and you can get in there and watch back the webinars that we've already delivered, listen into the podcasts, and all of our attendees today will be sharing some of the research and thoughts on there as well. So please do sign up. But that's all the background. This is a great conversation, one that, as we discovered, we don't feel that people are having enough. As ageing is going to be happening to us all. But let's crack on here from our panel. So we'll start with Teppo. Thank you for joining us today.
Thank you, Lucy, and thank you for the introduction. I'm really speaking now to you here from Finland, and maybe just to mention about my background, I also am a social worker by background, so I think there are quite many social workers here also speaking in this panel. I will now try to share my screen. Let's see how it goes. Are you starting to see the
we
slide?
can see that. Yes.
Okay,
Perfect.
great. Okay, so and now I can finally come back to the task that Lucy gave to me, how to pronounce the name of my university. Well, we usually say University of Jyväskylä, so apologies for a difficult name. But in any case, I will be trying to in these 10 minutes to give you a brief general description of how the pandemic been going on here in Finland, particularly in social care and for all the people. And when I was making this presentation, I understood that I have promised a bit too much, because I also promised to cover findings from 2 different surveys and well put together with the general description that was maybe a bit too much. So I will actually not be able to go into any details of the surveys, even though I will mention them here. So very briefly, the COVID-19 hit Finland a bit later than many other countries. Well, we are on the outskirts of Europe, so it took a bit longer for the virus to come here, but it did come. And in the beginning, our government was also a bit slow in responding to the pandemic, but in the end they did respond, and quite extensively. For example, our capital region was isolated from the other parts of the country for a few weeks, something that earlier would have been unthinkable. I was really surprised to see that the scale of action that the government in the end did. One part of the measures was that the government strongly recommended all people who are age 70 or over to self-isolate, to self-quarantine themselves, and people took that really seriously. So basically, they cut all visits, all interaction, physical interaction with their children, grandchildren, friends, neighbors, and just stayed indoors or going outdoors for quite a long time. Also, all kinds of social activities for the people, hobby groups were cancelled, and this is where our first survey comes in this so-called DACO survey that we gathered among all the people last autumn. It showed quite an extensive amount of loneliness, anxiety among all the people. Their well-being and health was clearly going down, because we also have some earlier data that we could compare the results to. So, well, this is not a big surprise, but it was really very clearly shown by the empirical evidence that we had. Then we are participating in another survey, which is actually a European survey run by the Eurocarers, and in Finland that was also performed among family carers of all the people, and also there almost all indicators showed a way downwards. So many services were cancelled for carers, their respite care periods, peer support groups, other social and healthcare services were put on hold, and clearly this was quite a difficult time for family carers. That is also quite visible in the survey data. Well, going forward, what happened in Finland, and I guess this was quite the same in many countries, that first the focus of the authorities was very much on healthcare, and particularly these intensive care units. It was about their capacity that was the main issue, and also the personal protective equipment, different kind of guidelines were focused on them, and in the beginning, also in Finland, only people who were dying in hospitals were counted. So all the people dying in care homes were actually in the beginning ignored as part of the pandemic. But there was quite a lot of public debate. Some of us as researchers also participated in saying that this is not enough. Care homes need to be included in the distribution of the protective equipment. There need to be very careful procedures how things are done in care homes. For example, that it's not enough that the staff uses the protection only when they are working with infected older people, because actually it's the staff that is the risk who bring most often the infections into care homes. Also, other arrangements were discussed to keep the flow of people as low as possible in care homes, including minimizing the moves of older people between different units, and also trying to use the substitute workers in a more organized way than usually. Basically, after some discussion, all of these measures were taken up in Finnish care homes, and I think they really made a difference as the number of infections. In the beginning, it was going up, but then it started to come down quite quickly. Well, there were also other measures. I think these are very familiar to you. Visits to care homes were banned. Even older couples were kind of separated. There were these quite heartbreaking pictures where you could see the partner was outside behind the window and the other partner was inside, and they couldn't see or touch each other, even when the one of them might be in a terminal stage. Also inside the care homes, there were many limitations. Social activities were limited. Interaction was also limited. A lot of DNR decisions were made quite quickly, and I must say without maybe very proper consideration. And also we could see that not so many older people were moved to hospitals, and particularly into intensive care units. There was a discussion whether this should be happening or not, but this is how it went. But one positive thing, it was found out that actually our staff in care homes have quite good nursing skills, as all of them basically have a 3-year training, and that was really useful during the pandemic. Here's a figure that shows quite clearly the connection between the general level of infections in the population and then the number of deaths in care homes on the vertical dimension, and it's really very impressive for a researcher. Finland is not mentioned here, but Finland has been very close to Norway, so on the bottom left corner. But I think why Finland, the care homes in Finland haven't got a huge number of deaths was really protected by keeping the infection, the epidemic low in the community in general. Well, this year, as we know, has been gradual recovery. There are still problems. Some care homes have still had deaths. There has been kind of this local situation where there have been quite a lot of infections in some care homes, but gradually these have been disappearing. There still have been some problems with having particularly the better kind of protective equipment, but gradually the visit bans have been lifted. Vaccinations, as you know, have been coming in slower than in Britain, but particularly since March they have been really speeding up. What we have found out, there's been really a kind of a leap in the use of digital communication equipment among older people, keeping contact with their kin, something that the Australian professor Loretta Balthazar calls digital kinning. social activities have been gradually opening, and on the other hand, as a kind of in a way negative consequence is that as Finland was not hit so hard, for example, like Sweden, we haven't had this kind of large public discussion that the care system needs major investment in the future, which is happening, for example, in Sweden. But in general, this spring has been bringing more and more hope. And for example, 3 weeks ago, there was one quite touching story in the leading newspaper of Finland, Helsingin Sanomat, where finally, after more than a year, grandchildren could finally visit their grandparents when the grandparents had already had their second vaccination. And it's really these kind of pictures are also bringing hope, not just for these people, but for the whole population and for all the people in general. Well, finally, some lessons that I think can be drawn from the experience of Finland during the pandemic. First of all, it's quite clear that it's really the general measures against the spread of infection that are the best protection also for all the people, including people in care homes or in home care. And social care gets very easily forgotten when emphasis is put on healthcare under this kind of conditions, but that should not be so. Care homes and also home care are vital for all the people, for their health and well-being. It seems that the self-quarantine for all people aged 70 plus was a bit kind of too imprecise, because there's a huge variety of people's health conditions and social conditions in those age groups. There could be people with a 35 years of age difference in the 75 plus group. Well, social interaction proved to be really important. When it was cut down, we could see how much it really matters. This is what we don't usually really understand so well, but now it really became very, very clear. This is my last slide. I'm almost at the end of my time. The nursing skills that our care staff in Finland have proved actually really useful under these conditions. On the other hand, the medical doctors, their visits were cut down. They were too busy with their other work, but that was really a problem for care homes. Another two things that there's development and the pandemic brought quite clear in Finland is that the importance and the breadth of care and support that grandparents provide their grandchildren became very visible. And actually they are also helping other people, including their adult children in many ways. And when this was cut out, people found out how important that is. And in general, also the key role that all the people play in our societies, when that was reduced, we found out what we are actually missing. On the positive side, we could see that actually younger age groups, younger generations are actually really ready to make also many kind of sacrifices and limit their lives in order to protect the older population. So in a general perspective, this was quite encouraging. Thank you.
Thank you, Teppo. I have a few questions for you. I'm sure the panel will as well. You mentioned digital kinning, and what technology did you see being used the most to make those connections?
Sorry. Well, all kind of technologies. I think maybe WhatsApp might be the most popular one, but Skype, different kind of home programs to call, particularly video phone calls. I think this has really went up quite a lot. Of course, not everyone has been able to take this equipment, particularly if people already have dementia or memory problems. But many people have really been extending their use of this new equipment.
And again, I guess that's another challenge is with care homes is having that technology available to their communities.
Yeah, that is also very true. There were also quite many kind of donations that particularly businesses donated, for example, iPads for care homes, so that they can then use this for connections, making connections between family members. Of course, it has also taken some time from the already very burdened care staff to then to learn their residents to use this new equipment, but it's been very, very useful.
The impact of doing so, I think a lot of potential technophobes in the older generation have embraced it because it has allowed those conversations to take place. There's suddenly a need for technology that maybe there wasn't before. There's a couple of questions we have here. Felice has asked, what are the key roles that older people play in communities that you saw? Quite sort of specific roles that you saw that they had.
Yeah, well, I think that is in general in many areas of lives. Also for supporting other older people, that was also cut down when all people aged 70 plus had to self-isolate. So there's a lot of this kind of NGOs, many voluntary associations lost their volunteers. As a result, neighbors couldn't support each other in many ways, and actually we could also see that in this age group there are many very skilled, even specialists in many issues that then suddenly became unavailable under these conditions.
It's like a discrete care system, isn't there? There's a discrete care system within communities, people just looking out and after each other, which got stopped.
Yeah, exactly. It's just disappeared overnight, and it was just a totally new situation.
And actually, Anula's touched on something. Was digital exclusion an issue for care homes? You mentioned that people were donating. Did the government have any initiatives there to address this as well?
Well, there were some initiatives, but in Finland the care system is very localized or decentralized. So actually it is the local municipalities who are responsible for care homes, and there were quite big differences between different areas in Finland. So I think in bigger cities they were quite quick to organize these digital equipment, but particularly in the countryside that must have been quite slow in many areas. So also these local variations came up, and certainly that is something to address in the future.
And my final question before we move on is, obviously you had that chart around the deaths in care homes, but you also mentioned that the deaths in care homes weren't registered at the beginning. So do you feel that data is, how inaccurate do you feel it is, that actually there's a bigger problem there than the government wants to admit?
Well, I think they got it solved in the end, but it took some months before they really understood that you really need to look at care homes carefully as well. It's not enough to look at deaths in hospitals or in home care. So
but reporting of COVID deaths is an interesting topic globally, isn't it?
Yeah.
So all countries seem to be doing it differently. Russia springs to mind as one with an interesting perspective of it, but it's just, I feared from what you said, it might be stopping those conversations happening around the evolution of care if they can kind of say, well, the figures aren't there. So I'm glad that it is being addressed. Thank you very much. And as Annie-Marie's mentioned, if there's any more questions, do put them in the chat, because we will come back to this after everybody has presented. But thank you very much for that. And can I please introduce Leah? Thank you for joining us this morning.
Hi, thank you. And thank you, Teppo, for a good and very interesting presentation. So I'm going to share my screen. Okay, hopefully you can
Perfect.
Yeah, good. So yeah, I wanted to present some findings from an field-funded project that we've been running. We're halfway through it. And the project looks at ethnic inequalities in later life. And we aim to document them and see whether they have changed over time. So if they're increasing or decreasing, and then also to understand the mechanisms, the causes of ethnic inequalities in health in later life. And the project, it's a collaboration between people at Manchester, James Nasru and Dermy Capedia, and myself and a research fellow at Sussex, Sarah Stopford. And so perhaps as a spoiler to my presentation, there are stark ethnic inequalities in health in later life. And I want to talk about them because this is where we were before the pandemic hit. And then we know what has happened in the UK with ethnic inequalities in COVID. And so the new normal, it's not very much new in terms of ethnic inequalities. And if we think about, if we think about the future of social care, I think it's important to also consider how can this be inclusive, and perhaps thinking about to reduce the inequalities that were there and have been exacerbated by the pandemic. So what I am showing you here is data from the 2011 census. And you may remember from the 2021 census that there are two health questions in the census. There's a question on limiting long-standing illness, and there's a question on overall health. And this question on overall health asks, can you rate your general health in the last 12 months or something like this? And you have 5 response categories. You can go from excellent, good, fair, bad, and very bad health. And what we've done here is we've combined responses to bad and very bad health into this category of poor health. And we compare the percentage of people who rate their health as poor across different ethnic groups and across different age groups. And there's a graph for women and a graph for men. And I hope you can see the different lines represent the different ethnic groups, and the legend is at the bottom. And the first thing that we see is that at midlife, so between 30 to 39, ethnic inequalities in health become really apparent. So people who belong to Bangladeshi, Pakistani, Black Caribbean, Indian ethnic minority groups, which are the lines in red, purple, blue, and this nice dark blue, have worse levels of poor health compared to people who belong to the white British group, which is this line in green, like, military green, one could say. So this is the first thing, that ethnic inequalities really expand in mid to later life, and they're quite apparent. And then we can see that these inequalities in health across ethnic groups compared to the white British group magnify at later lives, right? So in the later stages of the life course, there are really big inequalities. And Sarah Stopford has really made this very clear with this graph. So in the circle of the blue line is the white British health. So you can see that by the time, in general, the average white British person, men or women, are in their 80s, around 20% of this group reports poor health. And this is the same level of poor health than Black Caribbean men and women 10 years younger. So you can see, so this is the rate of poor health for white British women, and this is the rate of poor health for Indian and Black Caribbean women. So it's about the same between 20 to 25% of this group report poor health. So the level of poor health for white British women in this case, but it's the same for men, is the same in their 80s than the rate of poor health for Black Caribbean and Indian women in their 70s, so 10 years younger. And if we think of Pakistani and Bangladeshi women, the rates of poor health of Bangladeshi and Pakistani women in their 50s is the same as the rate of poor health of white British women in their 80s. So there's a big gap. And these graphs represent very clearly the inequalities in health at the later stages of the life course for some ethnic minority groups. And this is very descriptive. So here we're just plotting rates of poor health across different age groups for different ethnic minority groups. But when we do this using survey data and we take into account socioeconomic inequalities, so we take into account the fact that people have different jobs and different incomes and different education levels, and all of these impacts on health. If we were to take all of this into account, we still see these stark ethnic inequalities in health in later life. And this is just 2011 data. If we go back 10 years earlier to the 2001 census, we see that these inequalities they persist, they remain over time. So what you can see in all of these graphs, this is only for women, but it's the same measure of poor health And it compares the rates of poor health across ethnic minority women compared to the white British women. So this is the reference level of health. And you can see it for all of the other ethnic minority women. You can see it in this dotted line over 1. So if these lines go under the dotted line, one could say that these ethnic groups have better rates of health. They have better health, so they have lower rates of poor health than the white British. If the lines go over the 1, then we say these groups have higher rates of poor health, so poor health than the white British reference group. And in the black line, these are the figures I showed you before for 2011 census data. And in this diamond white line, this is the data for 2001 census, so 10 years earlier than the 2011. And what you could see here for all ethnic minority groups is that levels of ethnic inequalities and health have persisted or worsened over time, right? So if we think, for example, Bangladeshi women or Pakistani women, the rates of poor health compared to the white British women have worsened, or they are higher than they were in 2001, in 2011. So there's a persistence of stark inequalities in health in later life, as we can see here. And again, this is just census data, but when we look at survey data, we see the same. So over a 20-year gap, there are stark inequalities in health when adjusting for the socioeconomic inequalities that can partially explain ethnic inequalities in health. And this is really stark in later life, but inequalities occur throughout the life course, right? So we see the stark inequalities in later life in health, which are the result of socioeconomic inequalities and health inequalities that have occurred in earlier stages of the life course. So for example, studies have shown that in midlife, most ethnic minority groups are more likely to live in poverty compared to the white British group. They are more likely to be disadvantaged in the labor market. They are more likely to live in the most deprived areas in the UK. And these are just some examples, but we can see inequalities in education and in income, so not just in employment. And so there's a direct link between socioeconomic inequalities and poor health, but there is also a direct link between experiences of racism and poor health. And racism and discrimination impacts on health directly, but also indirectly through leading to these socioeconomic inequalities in health. So when we think about what are the drivers, the key causes of these stark and persistent ethnic inequalities in health that we see in later life, studies and science shows that it's actually socioeconomic inequalities through the life course that is driven by racism and discrimination. And racism and discrimination also directly impact on poor health. And I have just shown you one measure of poor health, but other studies have shown these inequalities with other outcomes. So quality of life, for example, or loneliness, and worse pensions. I want to show you a video, I hope it works, which contextualizes these inequalities over the life course and the role that racism and discrimination has to play. So I hope it works. Let me try.
People from minoritized ethnic groups have poorer health across their lifetimes when compared to the white majority. Health inequalities are caused by social and economic disadvantage resulting from experiences of discrimination, racism, and marginalization. This disadvantage accumulates across the course of their lives, translating into many lost years of good health. These differences in health outcomes accelerate and become particularly pronounced as individuals reach mid to late life. Researchers from the universities of Sussex and Manchester analysed data from the 2001 and 2011 census of England and Wales to understand ethnic health inequalities in older populations. Findings show stark ethnic inequalities in health in later life. Levels of poor health for Black Caribbean men and women in their 70s are equivalent to levels of poor health for white British men and women in their 80s. Pakistani and Bangladeshi people have the same levels of poor health as white British men and women who are 10 or 20 years older. Older, minoritized ethnic groups are one of the most disadvantaged in society. Existing research shows that health inequalities in later life are the result of accumulated disadvantage and experienced discrimination, racism, and exclusion over a lifetime. To eliminate ethnic inequalities, we must recognize how racism influences opportunities in society and how disadvantage accumulates across generations to negatively impact on health. People from
So that was prior to the pandemic. There are stark, persistent ethnic inequalities in later life, in health, but also socioeconomic outcomes. And then the pandemic hit, and we all know the tragedy that this is. And despite the news about the inequalities in the pandemic because of ethnic, because of racism and how this translates to ethnic inequalities in COVID and all the outcomes you can think related to COVID. Despite this and the vulnerable position of ethnic minority older people, there has been very little research focusing on the impact of the pandemic on this group. And this empirical invisibility is not new. So in February 2020, before the pandemic hit the UK, we published an opinion piece discussing how there's very little data and that can allow us to really understand aging processes for minoritized older populations. And then we see this happening again in terms of the pandemic. But the studies that have shown or have looked at this population show that Black Caribbean, Black African, Pakistani, Bangladeshi, and Indian older people were more likely to have died from COVID in care homes compared with the white counterparts. And studies that have looked at inequalities in social care and healthcare services have also shown that there have been ethnic inequalities. But there isn't many resources being put to examine this. But we know, and if more were done to research this, we would see that these inequalities have magnified and exacerbated in the pandemic. So what I wanted to ask all the panelists and the people attending is, if we are thinking of the new normal and the future of social care and how can we use this innovation and this opportunity for improvement as we think of building back better, how can we make sure that everybody benefits from this, that inequalities that have been documented and that have persisted over decades are redressed? And so how can we make the future of social care more inclusive for everyone, really?
Thank you very much, Leila. It's brutal, isn't it? That information. It's the fact that it's not getting better. Maybe naively, you hope that it's more progressive than you would perceive. Teppo, did you want to ask Leila your question directly?
Yeah. Thank you for very impressive and but also sad findings. But I was particularly wondering, do you have any kind of explanation or elaboration on the big differences between different ethnic minorities, for example, between people with Chinese and Bangladeshi background?
Yeah, I think we cannot compare. I mean, we can compare, ethnic minority groups to the white British population, but not ethnic minority groups are not one group that is similar within them. So there's really stark differences within ethnic groups, and the ethnic minority groups that you see most disadvantaged in terms of health are also the most disadvantaged in terms of socioeconomic position, for example. And so it's really, racialization of ethnic minority groups differs, and so though their outcomes, their histories of migration into the UK, and how they were received once they arrived is also very different. So they're very, ethnic minority groups, although they are minoritized, they differ greatly between them. So one would not expect that all ethnic minority groups do worse in the same way compared to the white British. Yeah.
And that might link into another question that we've got here from Anne. So in your figures, it looks like inequalities were greater for women, particularly comparing women in Asian groups with the white majority. Is your project exploring intersectional differences in the mechanisms driving inequalities in health?
Yeah, this is a really good question. So I think, for example, for the Indian group, we see that Indian women have worse health than white British women, and this may not necessarily be the case for Indian men, for example. So yeah, there are differences across gender within ethnic minority groups. And the reasons for this are complex, but then that's when if you link to systems of oppression like racism and sexism, then you can start to think about the theorize about the causal explanations. In terms of our data, we are really restricted by the data we have. So in the census, for example, we can create bivariate statistics with different variables, but it's really with the survey data that we can start to really tease the differences and look at the nuanced differences across or within ethnic minority groups. And we are really restricted by numbers. So if we restrict to later life, and then we start to divide across genders, and then look at the socioeconomic explanations, then we really run into a problem of sample sizes, which is a long winded explanation to say we have theorized about the possible explanations, but we haven't been able to empirically examine those. Across.
As you say, there are many layers and many factors. As you say, it's not easily defined, is it? There's so many pieces from that. And Teppo, I know you're speaking to Rob on the chat there. The question is, you mentioned some of the issues providing healthcare to older people in more rural locations. What is Finland's approach to providing specialist developments beyond just care homes? And the negatives of older people remaining in their existing homes when these homes become unsuitable, inefficient for receiving and providing high quality care in life. Now, Rob, a good question is about what you mean by specialist developments. We're waiting on that, but Teppo, do you want to kind of look at the rest of that question?
Well, of course, it's very important to talk about other parts of the care system than just care homes. These are just the tip of the iceberg, and the most people live in their homes in the communities. And absolutely, I fully agree that we should particularly look at what kind of support assistive devices and so forth they can receive in their homes. This is of course absolutely vital and important. And in Finland there are for example several kind of devices available, or it's possible to get public funding to renovate your home to fit better with your care needs. There's also home care available, but that has become more limited recently. For example, it's kind of household tasks are not anymore covered by public services in most municipalities. So there's certainly a lot of unmet need also in this area in Finland too.
There's still some developments there and still some challenges.
Yeah. Absolutely.
Cool. Thank you very much. And thank you, Leah. If you have any questions that are coming up as we keep talking, do put them in the chat, because this is a great conversation. But Philip, well, thank you very much for joining us. Welcome.
Thank you very much, Lucy. Thank you, Teppo and Leah. It's great to hear some of the academic and see the data behind this discussion. And what I've got to say is away from the data and the academic approach. I'm principal social worker in adult social care in East Sussex, and we are grappling on the ground, if you like, with the challenges that the pandemic has thrown up about how we work with older people. So I'm going to say a little bit about that and how we've been using virtual technology more as a result of the pandemic, really. So first thing to say, East Sussex as a county, we're a county with one of the highest proportion of older people living within the UK. So making sure the way we work with our older people is really important for us, because they are our biggest client group as the social services department. And that keeps us focused all the time about how we work with them. And that as well, we're a big organization, and we have to be really careful about keeping our services individualized, because older people are not, and this has already been said, they're not a homogenous group. And yet we still often hear about the term the elderly being sort of pushed around in the media. Even our politicians and leaders talk about the elderly as if they're this sort of one big group of the same people. And for someone like me, who's not too far off being the elderly, I don't particularly relish that description. And my friends who are also not that far off being the elderly are very different to me. So it's really important that we keep thinking about this group of people as a group of individuals. And for me as principal social worker, that our social workers approach that involvement with them as person-centered, looking at their individual needs. So there's a huge variety of types and level of need from the people that we work with. You know, they've got different views, beliefs, backgrounds, languages, and the way we work with them needs to recognize that diversity if we are to deliver truly person-centered social work interventions. I thought maybe it was a little bit worth saying a little bit sort of a historical perspective, really, a reflection on how we've engaged with clients and carers. You know, when social work first started, I guess it was pretty much all face-to-face. That was the only way that people could engage with clients and carers. Many clients, if we're going back, 100 years, not many people could read and write. So you couldn't send out letters and communication. There'd be no method often for sending it out. So it was face-to-face. Written communication then developed, and then the telephone. And we've all in social care used the telephone a lot more over the years. Many local authorities have contact centres, call centres, sometimes called. East Sussex certainly does. We have our front door to the organisation is through a contact centre, and that is largely telephone. And then more recently, of course, virtual contacts, what we're using today. And the pandemic undoubtedly has radically changed the amount of use of virtual contact for all of us in all parts of our life. We all know that. And that includes social care. But how do we get that right? And in what circumstances is it good to use it? And when doesn't it work? And one of Leah's questions was about how do we kind of address some of these inequalities? And I think one way of beginning to look at it is to recognise the range of needs of our older people and to see that they are very different. And I kind of think of it as a continuum, that we've got one at the start, we've got older people who understand their needs and can describe them. So when we engage with them, telephone may be perfectly adequate to do that. They can describe their needs, they can have a conversation with us. We don't need to impose ourselves on their lives, we don't need to turn up at their front door. And lots of people, quite rightly, don't want social workers turning up on their front door. The thought of contacting social services in itself is maybe a huge issue for them. So a discreet telephone call is all that's needed. And then maybe a bit further down that continuum, we've got people who've got family and friends around them who are supporting them, who can describe their needs and help them engage with services. So involving them, if you think about that, then maybe virtual contact there is, beginning to look at that, because we can connect with them. We can connect with them as a group, and they can support them to talk about their needs. So that's another step along the continuum. Then we've got people who don't recognise their needs and have no one to help them engage with our teams and services. Getting harder then to see where you can use virtual contact. Then we've got people who do not recognise their needs and don't want our engagement. That's very more challenging. And then, the sort of far end of the spectrum, we've got people who do recognise their needs and definitely don't want our engagement. So I think that kind of continuum is useful for thinking about where virtual contact can fit in. And to my mind, it's another tool alongside now face-to-face, written communication, telephone. It is another tool that we can use appropriately and have had to use. And the pandemic has forced it. We are using it a lot more with our clients and carers. We have had concerns about some of that use. Some of the platforms are less secure. So our carers, our clients, they're familiar with using Facebook or WhatsApp or Zoom, which we're using today. Our authority uses MS Teams because that is the most secure way of doing it. So how do we align that? Do we force all our clients and carers to use MS Teams as well? Or can we adapt these other methods to use WhatsApp, to use FaceTime? It's a challenge for our IT departments because they're not recognized as so secure. But on the other hand, we've had to adopt risk assessment that if actually the only way of contacting someone who is really at risk in the community is to use FaceTime, and that the data security risks are lower than that risk of not contacting someone using WhatsApp or FaceTime, then there have been occasions where we have used that. And I think we need to think about those risks and balance them while we developed IT systems that are fully secure. What else do I want to say? Just having a look at my notes here. Yeah, I mean, there have been some good use of IT with care homes, and I was interested in what Teppo was saying about in Finland. There's been a lot of donations to care homes, and I think in this country, in East Sussex, some care homes have been right on it. They've probably got 1 or 2 key staff in their care homes who can use IT, and a donated laptop is suddenly made that care home accessible to all sorts of people. Other care homes have not had that. So there's been a lot of hit and miss around, the ability to engage with care homes and staff and clients living in there. And that is something for the future that we need to sort out so that all care homes have got the same level of accessibility to IT, and that residents living in one care home can have the same contact through virtual technology. We have found as well with mental capacity work that sometimes actually using virtual technology for people with dementia has been better than face-to-face, and we need to recognize that. And when I say that, we've had situations where it has been less intrusive for people to look at a screen with their carer alongside them and talk to someone than for us to go in as a new face and into a care home or into a family and talk to someone face-to-face. That has been more alarming, or could be more alarming, than actually engaging through technology. And that's been interesting and quite challenging for social workers as well, because as social workers, we probably come into the profession to engage with people face-to-face, to build relationships, and to find actually that some people would prefer and find it easier to engage using IT is a challenge for our value base. But I think it is a challenge we need to accept and work on. And I think my final point really is when the pandemic hit, we had to produce guidance for our staff about when to visit face-to-face and when not to. And that was all about the risks of infection. But the policy, the guidance that we produced, I think actually is very applicable to thinking about now as the pandemic restrictions ease, when we can use virtual technology. And I'm just going to read a little bit out of the guidance that was produced by myself and the principal OT. So it was set up around infection, but I think it stands for when to use virtual contact in the future as well. So deciding to visit face-to-face should be based on the specific facts and circumstances of the situation. There is not a blanket policy about carrying out or not carrying out a visit. Normal best practice for people we have not assessed before and are likely to have needs that cannot be assessed or met by other means is to visit the person, usually in their own environment. This applies to our key statutory duties, such as needs assessments, mental capacity and deprivation of liberty safeguards work, Mental Health Act duties, and safeguarding responsibilities. So I kind of think that stands, regardless of the pandemic, that if we can engage with people without visiting face-to-face, then why would we spend time traveling all over the county, imposing ourselves into people's homes and their private lives if we can use other ways of doing that? But when we do need to see them, if people are not accepting of our help and they're at high risk, if there are safeguarding concerns, people are severely self-neglecting and are telling us they're okay, but actually if we went into their front room or into their kitchen and there was no food in the fridge, we could see there was no food in the fridge, there was no power in their house, then clearly we need to go and visit people. So that's the kind of considerations we're thinking about on a day-to-day basis. And I think also, very final point, the legislation we work to, the CARE Act, the Mental Capacity Act, the Mental Health Act, the major pieces of legislation that drive what we're doing, are very clear about our duties that we have to meet, but they're not prescriptive about how we necessarily meet them. So I think there is a huge amount of room for creatively using virtual technologies as another tool for engaging with clients and carers. And social workers and social care practitioners, I'm sure, will embrace those, just as we've embraced the telephone and written communication when they have been new ways of working with clients. So that's kind of my thoughts from the front line, if you like, and very happy to take any questions.
Thank you, Philip. But I really like the way, I like your optimism for start. You're still smiling. I can only imagine the year you've had, but the fact that it enhances your toolkit, as you say, different ways to engage, using technology in a really positive way to have the conversation, nuances. I also thought your comment there about efficiencies, but how soon were you one of the first wave when lockdown was coming? Was it February, March last year when you suddenly had to look at how you do things differently before the official lockdown started?
Yes, I mean, virtually in March, when we went into lockdown, visits almost stopped overnight and staff were no longer in the office. That was very quick. Almost, immediately our practice changed. We were not visiting people nearly as often, and the guidance I just spoke about was coming out very quickly. I mean, in that form, it took a little while to sort of narrow it down, have a neat form, but practice changed overnight, and we were still able to meet our duties. And I think it was interesting that the government produced guidance, talked about the CARE Act easements, and I don't know whether people are familiar with those, but it was part of the Coronavirus Act that local authorities could take a much lighter approach to what they were doing, and that the CARE Act duties were eased or could be eased. But actually, the reality was that very few local authorities chose to use those provisions. It kept meeting people's needs and found creative ways of doing it. And certainly in East Sussex, we did not invoke the easements under the Coronavirus Act. We just found other ways of doing it. And if we still needed to visit, we did. Mental Health Act assessments in East Sussex continue to be face-to-face, and that's true for a lot of local authorities. But of course, we used PPE and other ways to manage those risks when doing that.
I would say your community needed you more than ever. I can kind of appreciate the logic of the government kind of taking the pressure off of you, but I think those people who maybe wouldn't have asked for help before would need it more than ever, because that kind of touches back on what Teppo was saying. They've lost their community, their infrastructure of support had been stopped. So they would be coming to you for help. And I actually loved what you said at the beginning about this issue with the world elderly, the fact that we all get grouped into this awful lump of negativity. It's an awful word, isn't it?
Yeah, it is. Yeah.
The nuances. So going forward, obviously we've had a year of learnings and trying, and are you putting a whole new way of working together at the moment?
I think most local authorities are. We have in East Sussex a programme called Being Digital, which is looking at every aspect of what we do to see how we can use digital technology to go about our work, to be, you know, we are resource constrained. We have to find the most efficient way of doing what we do while still meeting our duties under the legislation and providing high quality social work. So yeah, we're reviewing everything we do to look at digital technology and how we can use it.
And how have you addressed digital poverty? Obviously, a lot of people, I imagine, in your community don't have the tech, can't afford it.
I don't think we fully have addressed it, and I don't think any local authority has. It's looking at how we can do that, but I think that's what I mean by we still have to have other ways of engaging with people, because we need to recognise that not everyone can use digital technology, or if they can, they haven't got access to it. I think that will change over time, and there are all sorts of schemes up and running and money going into improving access to technology. But until everyone can and wants to use it, we have to have the range of options.
And I think that last point's really good, is wants to use it, because we can make technology cheap, accessible. There's lots of, you know, you can get very, very cost-effective mobile phones, can't you, and voice engagement, but there's a whole raft of people who don't want to use that technology, and we have to respect that.
Yes, and also, I mean, for like I said, social workers as well, we don't want to use technology all the time. We want to have face-to-face contact, relationship-based social work. And yeah, I think if it all moved to telephones and virtual, I don't know whether we could recruit the social workforce, because it isn't what people come into social work to do. But I don't think that will ever be the case, that we get to purely virtual contact, given the challenge, the problems that we're dealing with our client group. Self-neglect is a really difficult one within the older population. And a phone call to older people who say, yeah, I'm fine, I don't need you, isn't often the reality. So we do need to be able to go out and see people.
But as you say, building relationships and trust is very difficult, if not impossible, to do on a screen. And so those people who need your help the most, you need to build those relationships with to a different level.
And it may be that you start that relationship face to face, and then people feel they've got the confidence, if it's their annual review or they need to get in touch about something to adjust their support plan, that can be virtual, but that they have met someone face to face at the start of that process.
It's easy to do the touch points, isn't it? As you say, a blended relationship building, and then maybe keeping in touch on a screen or on a phone. Yeah, but it's fascinating. As you say, it's still evolving. There's lots of learnings you've taken, but we're still not in normality yet, whatever that new normal will look like. And we have to embrace that the demographic, as we've discussed many times, is huge. With mental and physical requirements, it's something that you're still learning. But I really like what you said about your team as well. And there's an element there of the people who are giving that support and what motivates and helps them do their best work too. Thank you very much, Philip. And Lisa, we're going to finish with your presentation. Thank you very much. Thank you for joining us this morning.
Hi, sorry, I'm not very good at technology this morning for some reason.
It worked perfectly in practice.
Right. Okay, hi. So thank you for staying that long for these sessions. So this will be the last presentation for today. Okay, so right, I'm going to talk about the training and the support needs for the aging care workforce, and like it's a lesson that we learn from student social worker and the volunteers through the COVID-19 and from their experience. So just give you the background rationale. I has been interested in care workforce in terms of the numbering, the quantity of people who taking care of older people, as well as the capability of care professional and care staff in aging care. And that is because through my previous study, cross-national studies in UK, the Netherlands and Taiwan, there's an overarching finding about the quantity of care workforce is interlinked with the quality. Especially there is a care workforce shortage, there is the concern of a numbering of the care workforce and the capability as regard to the complexity of the individual older people, like previous colleagues speaker will mention about, not only about the multiple health conditions, socioeconomic, but also about the ethnicity, minority, diverse ethnicity has constituted to different culture needs, for examples. But during the COVID, there is an increased number of student social worker who apply for the care qualifying course, but also have an increased number of volunteers who join in to taking care of older people. So for example, like one of the charity that I'm working with, they have a 40% increased number of volunteers during the first 3 months of the lockdown COVID in England. So today I'd like to share with you 2 projects I have been working with. So the first one on the left is called Book of Can, and that is the project as regard to reflectivity embedded into social work education with 7 other international social work colleagues in their countries. And the right-hand side is staying together, recovering together. That is the very rapid research that we conducted with the charity called Time to Talk Befriending as regard to what is needed for the support to the old people who must work live alone in the community and for their volunteers. So just give you a very brief introduction about the Book of Can, the reflective journaling that I'm doing with 7 other countries as regard to social work training. So the right-hand side, you can see 1 page, and that is 1 page of many examples of a Book of Can. So it's a reflection journaling. Basically, it's very much encouraging students to emphasize on visualizing their making meaning of the knowledge they have learned. So what they do is they entered the visualizing meaning making of the knowledge they have learned after the teaching, and at least once a week. So that is an example of what we call Book of Can. And the left-hand side is a preliminary survey finding as regard to transformative process, students' transformative learning outcome, and their satisfactory of the way of using visualizing journaling to support their learning process. All of the elements are presented to be positive. So far so good, and we are still in our middle of studies. Okay. So what we learned from those 2 projects that I like to share with you is that there are some commonality between student social worker and volunteers who do a lot of important work in the community with the aging population. So one of the commonalities is once upon a time, there was a little small interaction, and once upon a time, there was the physical seeing and holding as well as hugging. So those quotes has presented that people start to appreciate, but also missing this kind of a human contact. So the overarching finding from those 2 groups, students and volunteers, are that there has been a growing appreciation of human contact, as an essential part of education and practice. In addition, there is also a growing empathy and interdependencies during the COVID-19 in terms of social work education training and in terms of the volunteers who are supporting old people in the communities. So social worker student in England stated that maybe more empathy has grown during the pandemic in social work training, and just an understanding of what students' stress can do to students' cognition and their emotions and their patience. So when students see somebody and they know that they have been through a lot and yet just less stress, like student kind of had more first-hand kind of ongoing unrelenting stress that students think a lot of the client that they see might be going through. So is this kind of connection already building up and empathy already grow during the social work education before qualifying? For volunteers, there is a common or shared feeling of interdependencies. It's not only see the volunteers' work as helping people, it's an interchange relationship that volunteers find helping people is a way to helping themselves as regard to reduce their own loneliness and isolation, but also as regard to feeling have a company and the feeling being worthwhile. So, all to say that with all the goodwill from student social worker or from the volunteers, there has been a challenge, I have to say. And this, on the right side, is another example of Book of Ken. The student reflect on how they feel while doing the educational process. And with a big print writing about I am still standing. Student challenge in terms of their resilience, like a previous quote, is a lot of stress and a lot of loneliness as well. So there is a growing need for support as regard to group support among knowledge exchange and peer support. So as regard to, from students' perspective, the knowledge exchange is there has been missing the interaction beyond the screen as regard to have a debate and have a grab a coffee, have a little chat, this kind of opportunity of having a sounding board that has support students to keep on engaging with their learning and learn from their peer as well. And for volunteers, particularly, they feel isolated. It's similar like the care professional, a lot of care professional lone worker, including social worker. We go out visit client as a social worker by ourselves. We don't normally pair with other social worker. Volunteers found it extremely difficult to support older people during the pandemic because a lot of emotions and a lot of loss, bereavement, and the complexity occurred during the engagement with older people. They are seeking support. They want to know how other people do it as a volunteer in their practice. Last but not least, the support as regard to loss and bereavement is particularly highlighted during the COVID pandemic for student social worker and for volunteers. And loss and bereavement is not only about loss and bereavement as regard to service user clients' experience, it's about loss and bereavement in their life as a social work student and the volunteers. They also have their family, and many of them have a bereavement as regard to family death during the COVID pandemic as well. It's very emotional challenge to holding the life and holding studying, work, and the caring on the same time. So I'm going to move on to what Phil was saying about the digital, yeah. So from the Book of Kent example, you can see that my student has reflect on how the digital impact on social work practice. And in the corner, on the left down corner of this Book of Kent page, students particularly emphasize that technology should be seen as a tool to engage, but not to replace in-person care. It's echo to what clients want, older people want. So from the Stay Together and the Recovering Together research, we found some old people said, for example, the first quote, "I don't like the assessment to be on the phone." Maybe this is also a message to our social work colleagues. It feels more connected when done face to face, especially when talking about personal things such as medical issues or injuries. Another old people said that really miss the in-person befrienders volunteers visit. When Ellen, the volunteer, rings, it's not the same as in person. So it's to further emphasize the human touch as regard to what Phil just mentioned about relation-centered care and person-centered care. The importance of open our ears and open our eyes is not new in social work training, but now it's increasingly important during the COVID-19. Students reflect on have to be open your ear and really listen, and seeing what is said as well. But in addition, there is a growing need of diverse communication skills now these days, since the massive introduction of various technologies. So befriending services, volunteers normally go to visit old people in person before COVID, but introduce the phone befriending, talking to older people during the COVID-19 pandemic. So one of the advantage or opportunity through the COVID is regard to the listening skills, according to the volunteers. But social work students also highlight there are a number of increasing newer skills need to be further emphasized, such as a communication by email and communication by phone, communication by screen. They all require different detailed communication skills. You can see from the final quote, the student highlighted that while doing the face-to-face, if you wear the mask, the eyes and the eyebrow movement is very important since you can't see the smile. So this kind of a non-verbal but so detailed communication has become so important at this stage. Also about the voice and also about tones if you are talking on the phone to engaging with older people. But it's important to know that telephone engagement doesn't always work for older people. So for example, it doesn't work with people who have a hearing impairment. Does not work very well with people with dementia, because they will be forgot about you called and forgot about the conversation, especially no engagement with the facial image is difficult to remember. Phone communication also doesn't work very well for people who have a very severe mobility restriction because they can't reach the phone in time before you hang up. And also phone doesn't work very well as regard to when working with older people who have a complex needs and is needed for the environment observations. Sometimes when older people say, I have food, I'm fine, I have eaten plenty of food in the fridge, it's kind of a reassurance for volunteers or for caring professionals. Just observe the environment and perhaps check about the expiring date of food. for example. Those things come down without in-person engagement. So finally, I'm going to talk about the needs for training. So apart from the communication skills, and there is also the growing need of training as regard to loss and bereavement. That is particularly about, not only about old people who might lose their family, who pass away, but also the loss of not able to contact the families, and the bereavement as regard to not able to see the friends and the family, but also about the shopping grocery. And most importantly, it's about the loss and the bereavement of the normal life that used to be the normal to the old people, individual old people before the COVID-19 pandemic. An increasing need of training on substance misuse, because from the Stay Together, Recovering Together research we found, there are increasing number of older people increasing their alcohol taken because of loneliness and because of isolation. And that has increased the anxiety and the depression as a result of some glass of wine or whatever during the day and the night. And that has caused some need for volunteers and for care professionals to have a knowledge on substance misuse as well, and the mental health due to increasing amount of anxiety, depression, as well as dementia care. So one thing that need to highlight it is that although there is increasing number of students, social worker, and the volunteers join the care workforce since the pandemic, but there is still shortage of care workforce in aging care. Nevertheless, and that they has been saying that for charity organizations, they are increasingly facing the challenge to fill in the gap of healthcare and fill in gap of local authority social care. As regard to the evidence of characteristic of people who they are support through the charity, many older people have a multiple health illness, and many people have with dementia. So you can see there is evidence of we still need to work on the care workforce for aging care in England, at least. Okay, so thank you very much for listening.
Thank you, Lisa. And do you know, my first question actually is taking your research, Lisa, and I'm putting it back at Philip, because one thing that Lisa really picked up there is carers looking after each other and supporting each other through this very difficult period. How have your teams supported each other? Not only your team, but also I guess you have volunteers as well. How have you changed the dynamics of those communications during the last year? Oh, Philip, you're still on mute. There we go.
Hey, yeah, well, teams supporting each other have used virtual technology for sort of, and I'm sure like lots of other organizations, coffee breaks together, team lunches together, catch-ups, all of that way of connecting and supporting has been used by our organization. And I'm sure that's the same elsewhere. I mean, I was interested in what was being said about some of the presentations about a closure or reduction of activity in the community because people couldn't see each other, but also the growth of volunteer organisations. And we've seen that in East Sussex, and I'm sure it's the same elsewhere, with community hubs is what's been created here, and a lot more informal support in the community, neighbours getting involved again, just very localised support networks forming. And we did some research talking to our clients and carers, and many of them fed back that they'd had more connection with their neighbours that they hadn't really seen or didn't know whereas suddenly people were knocking on their door or putting notes through their door offering to help. And that's been really encouraging and positive, and fits very much with our sort of approach to strength-based social work practice, about trying to enable communities and people to call on the strengths of their communities as well as the local authority. So we're looking at how can we maintain that, or will that all just stop as the pandemic goes away? Will people's energy run out for doing that, or can we keep that going and keep communities supporting and helping themselves? And
I really hope it's a positive, Philip. No, I think what Lisa was saying was it was so warming. People are wanting to help, wanting to look local. We were suddenly all forced to look locally, weren't we, physically? But it did make us really think about our neighbours and where we fitted in. I hope we don't lose that. I think if we can try and take some positives from the last year and a bit, it is maybe bringing some of that culturally back into our communities, that we look around us a bit more. We've run out of time, so that's a good sign. Thank you all so much to the panel for joining us. Now, if anybody has any further questions to the panel, what I would do is recommend that you come and join the Possibility Club. So this was us today. A great conversation around the inequalities. I have to admit, some of it's really disheartening, Leah, that it's not getting better, that this isn't new, but it is being compounded. I hope we get to talk about that, how improving next time we speak. So thank you to our speakers, Professor Tepper Kroger, Leah Beckeras, Philip Burton and Lisa Chen. Wonderful conversation, wonderful perspectives. As ever, lots of food for thought. I find these very reflective as sessions because there's still so much to learn. I really appreciated, Tepper, the perspective of different countries. I think one thing that's been quite hard to gain over the last year is international perspective. You've had to go on to find that. And I know there's a gentleman, Rob, on chat who's got a lot of interest in that as well. The final webinar is going to be on the 9th of June, how we can turn the problem of ageing into the most promising opportunity of the 21st century. I think one of our big missions of this series is to stop calling ageing a problem. It happens to all of us. Let's try and do it proactively. Let's try and look after each other and try and have as good an ageing as we can have, based upon whatever that might mean for each of us individually. And please join the Possibility Club, join the conversation rather, come and give us your thoughts. There's lots of debate, lots of ideas, and it's how we can take as many positives from this last year and improve the way we age going forward. That'll be our hope. But thank you all very much for joining us, and we hope to see you again soon.
Thank you, Lucy.
Thank you. Bye.
Thank you.